Hello, everyone, and welcome back to another episode of Mom Strength. This is your host, Sodabi Veach, and I'm really excited to have on two special guests today from Heart Health Matters, Dr. Karen Fleming and Karen Fung. So they are both Karens, Karen F. So I'm going to call Dr. Fleming, and we're going to call Karen Fung, Karen, just for ease of communication. So welcome to my podcast. Thank you both for being here. I would love to begin with asking you just to briefly introduce yourselves and what your mission is at Heart Health Matters.
I'm happy to start. This is Dr. Fleming here. I'm the Chief of Family Medicine at Sunnybrook Health Science Center. I've also been involved in delivering babies and following families across the lifespan for at least the past 25 years. Our goal of our website and our education programs is to build awareness of what happens in pregnancy and its impact on the future health of both the child as well as for the mother, the birthing parent.
That's something that I think a lot of people may not be aware is how it also impacts the birthing child or the child as well as the mother. And that these issues that happen in pregnancy may also persist postpartum or increase prevalence of disorders postpartum, right? Can you, and Dr. Fleming, thank you for the intro. How about Karen? Would you like to introduce yourself as well?
Sure. I'm Karen. I'm Karen Fung. I'm the dietitian, registered dietitian and certified diabetes educator at the Sunnybrook Family Practice. Work with Dr. Fleming. I'm also part of SUNDEC, which is the diabetes education side of things at Sunnybrook. And yeah, I run a lot of sessions with lots of different age populations with regards to, food, nutrition, and how it can impact our health and what to do. And yeah, I've been on this project helping with women with hypertensive disorders of pregnancy for a little bit. And also on the diabetes side, we've been running gestational diabetes postpartum classes for many years.
Amazing. Thank you. Both very, very valuable and important work. So let's get started. I would love to hear about what are the major hypertensive disorders in pregnancy and how prevalent are they? Dr.
So
Fleming? Yeah.
I was going to take that question. So about 7% of pregnant people in Canada will develop a hypertensive disorder of pregnancy. So this may be someone who has pre-existing high blood pressure prior to pregnancy, but we define pregnancy blood pressure, so someone who's not had any problems with their blood pressure prior to that time, if they develop high blood pressure after 20 weeks of pregnancy. So you can have gestational hypertension, which is blood pressure after 20 weeks of pregnancy that is by itself, if you will, and continues on, and you go through the pregnancy, things are managed fine, and you end up delivering, and that's the gestational hypertension. You can also develop hypertension with other features, and you may have heard people talk about preeclampsia, and that is a condition that has high blood pressure with it, but also it has impacts to other parts of the body. So people will have could have visual changes, they could have chest pain, they could have protein in their urine, and that is more severe usually than the hypertension in pregnancy. You can also have something called eclampsia, which is the preeclampsia with seizures. So seizures would bring you to a diagnosis of eclampsia. That is much less common because we've got medicines that we use and to reduce the risk of seizures, but we are watching for that. So it's a collection of health issues that have their first manifestation after 20 weeks of pregnancy. So there are some risk factors that would place people at risk of developing hypertension or preeclampsia. So first off, if you have high blood pressure prior to pregnancy, you are more at risk of developing preeclampsia over the course of the pregnancy.
And what would be classified as high blood pressure?
So blood pressure over 140 over 90 on two occasions. And this needs to be monitored. You want to test that's not just one-off reading, but it is a reading that you repeat.
And this is something that most people are getting tested during their monitoring, their routine monitoring with their practitioners. So this is really helpful information. What if somebody naturally has low blood pressure, but then it rises up in pregnancy? It's still below that 140 over 90. Would they still be considered to have high blood pressure if it rises above a certain amount, or is it the 140/90 that's the kind of the gold standard?
So that's a great question. And while we'll take that into consideration, the diagnosis would be a specific numbers.
Okay,
But
good to know.
if someone has it, we might be taking more notice.
Okay, because a lot of my patients have low blood pressure in pregnancy, and if there's a sudden spike, it's about where's the majority of the concern. So that's good to know. It's the absolute numbers. Okay. And then what are other risk factors? So you mentioned high blood pressure in pregnancy, or sorry, prior to pregnancy is a risk factor. What are some other things that might increase someone's risk?
So if someone has a history of kidney disease, if someone has a history of some of the arthritic conditions like lupus or rheumatoid arthritis, autoimmune conditions, family history. So family history is an important one. And so it's always great to know what your sister or your mother or your grandmother, if they had anything happen exciting in their pregnancy. So if they had diabetes in the pregnancy, if they had high blood pressure in the pregnancy, this gives helpful information for you to know if that's something that you are going to be at risk for, which is important because there are things that we can do that can reduce the risk of developing both gestational diabetes and the gestational hypertension of preeclampsia.
And is kidney disease in particular, does that include kidney stones, or is that what kind of conditions fall under that?
So it wouldn't be kidney stones, it would be people with underlying disorders of their kidney. That could be things like something called glomerulonephritis. People would know if they have it because they will usually have been doing follow-up with their primary care provider or seeing a nephrologist. So that would have been, that's a group that probably is already aware.
Or already aware of. Okay, that's good to know. Because I think some people just every symptom in pregnancy is so new, from the nausea to the fatigue. And so sometimes people don't know, is this a normal change in pregnancy or is this something that I need to be alarmed about? And so when people understand, okay, blood pressure, that's a very simple test, and they're doing that routinely with their primary care provider or their, OBGYN, their midwife. But the other things to consider, kidney disease, it's likely diagnosed prior, right? That's good. Any other risk factors to be aware of? Is age one, like it is for everything else, it seems?
Yes, it is. Yes, it is. Increased age and lower age is also a risk factor.
Oh,
So,
what would be considered lower then?
so if you're basically, we're not seeing that much, but they definitely under, if you're seeing someone under 18 or over 40, the risk is more significant.
Okay. Is there something people can do are there any other risk factors before we kind of move to the next question?
I think we've covered a lot of them. So things that we know that physical activity is great medicine, whether you're pregnant or you're not pregnant. And we have good guidelines from 2019 on physical activity in pregnancy, and a lot of data that suggests that physical activity in pregnancy can really help to reduce the risk of gestational diabetes as well as high blood pressure in pregnancy, and that this can be started ideally before pregnancy, but could be started in early pregnancy as well. We know that the guidelines are that 150 minutes a week. You can start slow and gradually increase, aiming for sort of 3 days of the week, although physical activity all days of the week is good, and it's moderate intensity activity. So walking is great. If people are already running, that is something that they could continue. Swimming is good. Stationary cycling, you want to be mindful of not bumping the bump. And so, downhill skiing might not be what you want.
Surfing, downhill skiing, maybe avoid those.
Maybe avoid those. Scuba diving doesn't protect the baby from decompression. So,
Yeah.
and there are good resources that are available for that, but there's really significant benefit of reducing risk for the hypertensive disorders of pregnancy.
And that makes me really happy to hear, because that's what, as a pelvic physiotherapist, I help people with movement and getting active through pregnancy, because, many people are limited by back pain, SI pain, pubic pain, fatigue. And one of my key jobs is not just symptom management, but is to also prepare their bodies for the pregnancy and birth and postpartum. And so strength training, movement, cardiovascular exercise is all part of it. So for anyone listening who's like, I want to be active, but things hurt, there are ways to support you to being active, which also helps you to reduce your risk for these hypertensive disorders. So there's multiple benefits for being active, right?
Yes, I mean, the data is pretty compelling, and pelvic floor is also in the guidelines of the importance of
Yes.
pelvic floor.
Pelvic floor training. Yeah.
Absolutely. So
Just a few more risk factors. It would be things like multiple gestation. That's a higher risk factor too, right, Dr. Fleming? If you've had twins, triplets, and then smoking is sort of the other glaring one that,
Smoking pre-pregnancy or during? Both?
Yes.
How about alcohol?
I'm not sure if there's a lot of, I guess, evidence around that, but
on alcohol, particularly with the hypertensive disorders of pregnancy, but we do know that that's not something that we don't want to be. We want to reduce and not use alcohol in pregnancy. So
yeah. And I was thinking more even prior to pregnancy. I was wondering if there's any literature, because we know about smoking, but I feel like nowadays it's more normalized to drink alcohol versus smoke. I mean, now though, there's vaping and all these other things that have come about. So does that all fall under smoking, vaping included, in terms
we
of
would
risk?
want to reduce vaping,
All of those things. Yeah.
right. So any substance use, we would want to tackle that as a separate and important issue.
Yeah. Yeah. And does it increase the risk factor if you've had multiple births? Like if it's your fourth child, your fifth child, does the risk go up or not really?
It's more, excuse me, it's more common in your first pregnancy.
Ah, okay.
And if it's happened once before, like most things, in pregnancy, it's more likely to happen again, but it's the first pregnancy is the time that people are most at risk.
Most at risk. And is there any information on the male, like the sperm quality? Does that influence risk? Because I know there's more research coming out now about sperm quality and it impacting, placenta health or, the health of the fetus. Is there any information about how that might impact things?
To the best of my knowledge, I'm not aware of anything to do with the quality of the sperm and the so
Okay.
timing between pregnancies is a potential risk.
Okay.
And length of time, but specific, no, not aware of that. I did get another risk factor, that elevated BMI. So entering into pregnancy with a healthy BMI would be ideal, and also looking at weight gain over the across the pregnancy is also important, which I think Karen could speak to much more eloquently than I can, because I have the luxury of referring to having a dietitian who works with me here at Sunnybrook.
So what would be, Karen, what would be a healthy weight gain for a pregnancy?
I believe it's 20 up to 23 pounds, but it does depend on where you start. So with the
Mm,
higher BMI that you start, a little bit less of a weight gain that we're ideally looking for supporting your pregnancy. And the lower your weight, sort of similar idea. Um, but I do want to preface that BMI is a crude calculation of health, and it is not the only thing that we should be looking at. That is why we support, your uh, prenatal and antenatal appointments with things like blood pressure, with things like blood work, and sort of just like your overall potentially nutrition that you may not talk about with your OBGYN and may not talk about with your midwife. But
mm.
are sort of important factors as well in physical activity. So, uh, although it was one of the things that, is a risk factor, it's not the only one and should not be. We're very careful
Yeah.
about what we talk about in terms of weight because we're understanding that we're not in full control of our weight, just like we're not in full control of our blood pressure. You don't wake up saying, I would like my blood pressure to be
Yes. Yeah.
120 over 80, right?
Yeah.
So, mhm.
And do you notice, and the thing with BMI too, some people have they have a big frame or a lot of muscle mass, and their BMI can show up as elevated, but they're actually healthier than the person who's, maybe smaller framed but has more visceral fat, or, there's so many factors to consider. So I like that you look at kind of that big picture. Do you find that there are ways to support people who or I guess going back to blood work, what you just mentioned, do you recommend people getting certain things tested in terms of their blood work? What are key things to look for?
So we have a lot of blood work that's quite standard for pregnancy. And anyone who's been through pregnancy realizes that we do a ton in that first, 3 to 4 months of pregnancy. We screen people again for their iron levels, and we do a test for the diabetes of pregnancy between 24 and 28 weeks. In pregnancy, there's not specific things that we would do preventative wise, but we do, if someone has symptoms or the blood pressure changes, then that will lead to us doing some different blood work. The post having a pregnancy that was complicated by high blood pressure for a long time now in the Canadian guidelines for who gets checked for the cholesterol. The hypertensive disorders of pregnancy has been in those guidelines since 2016. But while they're in the guidelines, we know from the literature that not everyone is aware of that, either the people themselves or necessarily the primary care providers, who may or may not even know that there was an issue in the pregnancy. And so
Exactly.
the
Yeah.
midwives and obstetricians will no longer be caring for people after they've finished their pregnancy and their postpartum period. So it's after that time, there are coming new guidelines that are going to bring all these things together, so that there are strong recommendations that for what should be done after pregnancy. So what should we be doing at 6 months after pregnancy? What should we be doing at 1 year? Which I think will be very helpful to provide a roadmap for people themselves, but also for the primary care providers, and hoping that we can set up good communication from the hospital to back into community care, or from delivery back to ongoing primary care. We know in healthcare that anytime people are there's transitions in care, that things can sometimes fall between the cracks, and
Yeah.
we see things that we maybe didn't have the opportunity to look after because we weren't aware. So this is where pathways become important. This is where having conversations with people like yourself and trying to get the word out, because
Yeah.
knowledge is power, and it's really important for people to know what their individual risks are and what they can do to change their future risk. Because just because someone's at risk for something doesn't mean it's going to happen. You can have the power to make some of those changes yourself.
And that's empowering because, sometimes people have a bad family history, or, maybe they have precursors, high BMI or high blood pressure to begin with. But it sounds like there's things they can still do regardless of, how they're starting out. And, it's interesting. A lot of my patients postpartum, even if they had, let's say, low iron and they needed supplementation or even infusion, postpartum, I'm like, okay, have you had your blood work checked postpartum? Almost always it's no. It's almost like they're cut off from care as soon as they're past that 6 week mark, and they themselves don't even know or don't think to go get things retested to see where they're at now. And in particular, if they're breastfeeding or chest feeding, or pumping, they're still nourishing their baby. And it's like you still need those nutrients for yourself and for your own body to heal, and then also to nourish your baby. So there's a lot of, even I don't know what the guideline is. How long do you wait to get your blood work checked postpartum, or what the recommendations are? I mostly just encourage people to go see their primary care providers or doctors to get that follow up. Um, and so if somebody did have high blood pressure in pregnancy, or if they did have preeclampsia, what would be the postpartum recommendations for support?
For support. So if someone's been diagnosed with high blood pressure in the pregnancy, or when they go to be discharged, they need to be seen at the 3 to 5 days after they've been discharged from the hospital. The reason for that is that we can see a change with the fluid shifts where blood pressure can climb. So if you're seeing a midwife or you're seeing a family doctor, they may do that visit concurrently. Or if you're not, then either your primary care provider should see you or your obstetrician, but someone should see you in that time frame. People really often know that they need to bring the baby in, but not
Yeah,
necessarily that there's
something for them.
because we sort of, I'm not pregnant anymore, so it's done, right? It's
Yeah.
and it is the beginning but we do need to be mindful of that, because the blood pressure can go up with those shifts in fluid. So blood pressure definitely needs to be taken, and we don't want to have people having to come to the emerge or otherwise when we could manage them and do the detective early. So I think that's a key message, is that if it's not over at discharge, you need to have that follow up and having that information travel with you back to your primary care provider is really key and critical, so that they can follow you and you can work together for future health.
That's a really important message. Really, really important. I think if people know that, okay, 3 to 5 days postpartum, the appointments are not just for your baby, but also for yourself, have your own blood pressure checked. Would it be blood work then, or mostly blood pressure checking at that point?
We would blood pressure checking, and it depends on all the other
All the other things.
you may need blood work. Maybe someone had a lot of blood loss of the delivery.
Yeah.
There's multiple kind of reasons why that's certainly key, having that check done.
And one thing to note is postpartum. I mean, there's so much sleep deprivation and stress, and it's such a big transition. And aren't those also risk factors for high blood pressure on, individually, like, stress and then you compound that with somebody who has maybe a history of high blood pressure in pregnancy. So to me, that's even more important to get checked postpartum, because now, if anything, your stress levels are going to be higher in those first few weeks postpartum, when everything is just draining and exhausting, and there's a baby crying and you're trying to figure things out, right?
It is a very busy time, and it's a hard time to prioritize parents' health and baby's health and sleep sleep deprivation is real. So we know that it's, you're going to go without some sleep at the start, and sleep is important for future health, for
And
sure.
that's one of the messages that we like to give new moms especially, but even moms of a second, third child, is that, they need to consider their health and their status immediately post-pregnancy, maybe that 6 week post-pregnancy, and then after that, it really fizzles out. But really, a key time is also that 6 month post-pregnancy, especially if you've had any type of conditions during the pregnancy, diabetes, hypertension, preeclampsia. Um, and that's where I think when you're dealing with sleep deprivation, learning about a new baby, and you're going to see your family doctor or your primary care provider, that you forget to mention, oh, by the way, I had this thing happen. I had to stay in the hospital for X amount of days. And, one of the messaging that we like to remind everybody, whether they're, 60 years old, but then they're having, a neighbor that is pregnant, is to remind everyone, like, don't forget about your health, aside
Yeah.
from the baby visit.
Yeah, that's so important. And I think partners too, if the, birthing person has a partner or kind of support system, maybe outsourcing some of that to them so that it's so hard in your brain to keep track of everything. And even as a healthcare provider myself, I've been to the doctor before where I've been like, how did I forget to ask that one question? It just escapes your mind. Or when I'm doing a postpartum visit with a patient and they're informing me how their birth went, they'll completely forget the fact that, they had a third degree tear. Like if I'm not asking specifically, it's just escapes their mind, right? And so I think it's important to be proactive and expect that you will forget these things. So either write it down, have somebody with you that they can remind you. I love the idea of, even if you have a neighbor, checking in on each other, that community support that we often forget about is so, so important. Um, One thing I was wondering, does the risk go up whether you've had a C-section or vaginal birth in terms of the postpartum, risk of high blood pressure or preeclampsia or any hypertensive disorders?
No, the mechanism of birth isn't going to impact that. So
Or like induction, all the interventions, they don't really play a role necessarily in the postpartum kind of.
in your postpartum risk of developing higher blood pressure or running into issues postpartum, no.
Okay.
We do know that if someone has early onset preeclampsia, so someone, and by early onset, I mean that if they had, say they were 28 weeks pregnant, or the risk to the future is greater when it presents itself earlier.
Earlier? Okay.
Is different than if it happens later or at term. So
What are the signs of preeclampsia? So high blood pressure. What are other signs for people to look out for in
so
pregnancy?
so regular guidance that we give to pregnant people, if baby's not moving, we want to, that's, fetal activity is important. Headache, blurred vision, somebody who has chest pain, or they're having difficulty with their breathing, or they've got pain in the right upper quadrant. Uh, these are, or they're having sort of bleeding from their nose or their gums. If you think about, it's a whole system. The preeclampsia can affect our whole system. So you're kind of starting head to toe at where things could be. And so we like to think that this is anticipatory guidance that people will be getting at their appointments, and not to say that every headache is a headache from
Preeclampsia.
pressure, not at all. It's just being mindful of the cluster of symptoms and when to come in, having a low threshold for being checked.
And
Particularly,
this is the tricky part because so many of those symptoms can also mean, you know, heartburn or shortness of breath because your baby's shoving up into your ribs and there's and even low iron, right? So that can also present as some of that breathlessness. So it's I think I like what you said about the cluster. So it's not just one symptom in isolation. It sounds like it's usually a cluster of symptoms in combination with, if the person is just has any concerns or worries, they can always go back to their provider and have them screen for it. Is there a certain like aspirin or something that people are recommended to take as a medication if they have high blood pressure in pregnancy?
So you're talking about aspirin for prevention. So
Ah,
So yes, we know that there's good data that starting someone with either a past history or a family history of some risk factor that places them at risk for having pregnancy to the risk for hypertensive disorder pregnancy, that starting aspirin between 12 to 16 weeks is has good evidence for reducing likelihood of developing particularly early onset preeclampsia.
preeclampsia.
So that's 2 baby aspirins or 162 milligrams here in Canada, and you would start that ideally taking it at bedtime. If we know that having a diet that, again, this is probably in Karen's world rather than mine, but wanting to make sure that your diet is complete with calcium, and if it's not, then a supplementation, but it has been associated with a reduction too. So
Calcium. I'd love to learn more about that. Yeah, Karen, if you could speak on that.
In terms of calcium like sources or
Yeah, so I guess how does calcium impact the blood pressure? Maybe understanding like the role of calcium and what are some common sources that people can um,
so
get
we know
calcium in.
so you wouldn't use calcium if you're getting enough calcium in your diet, you wouldn't supplement for a reduction
Okay.
of risk. But if someone has a diet that is low in calcium, then ensuring that they are getting a gram a day is important. And that's when being able to provide resources or having the luxury of being able to have them speak with a dietitian who can talk about the different, where they're,
Sources. Yeah.
what are the choices, because it can be hard to know. And
so
so
And a
it
regular prenatal would not cover that 1 gram of calcium. I guess it wouldn't be enough in a prenatal source.
it's most prenatals don't have a full gram of calcium. And I would say that the populations at risk are people who are vegetarian or vegan, or they have strong sensitivities to dairy, because those are still the best sources of calcium. Because also calcium from our plant sources are difficult to absorb. The bioavailability is quite low. Those are the folks who were a bit more concerned. So if you consume zero dairy and potentially you are vegetarian or vegan, you are probably not getting enough despite taking a prenatal.
And I really this is information that I feel like not everybody has, right? This is as a lifelong vegetarian, did not know that, with increasing the risk of even just the link with higher blood pressure, and it's not something that's widely known. So I think that's important, even if we have patients that are vegetarian or vegan or completely dairy free. I'm seeing that more and more now. A lot of people are going dairy free. And so, are other milks, soy milk, for example, is it fortified with calcium or is it still not as bioavailable because it's not from a
Yes, I would
animal
say
source?
that the dairy alternatives are quite good. The main component that lowers the bioavailability and the absorption of calcium is fiber. So those dairy alternatives don't have a ton of fiber, and so it's actually fine to have those as a source. So your soy milk, oat milk, and almond milks are frequently and almost across the board, at least in Ontario grocery stores, fortified with calcium. You are looking for that 30%, at least 25% of your daily value per 1 cup. That would be equivalent to a cup of regular cow milk in terms of calcium.
That's really, really good to know because at least then people have options and they're not just,
Yeah.
stuck with, because sometimes supplements people, um, get more nauseous when they take more supplements in pregnancy, especially if they have a lot of nausea. I don't know about calcium supplementation in particular, but I know sometimes when people take iron, it can constipate them and then worsen their pelvic floor symptoms and pain. So that's really good to know that there's other options out there. And speaking to a registered dietitian would probably be the best if they have access to one, because then you get customized information, for you. Can you tell me about, you mentioned gestational diabetes. Does this count as one of the hypertensive disorders, or is this something that's separate?
It's separate. It's
Because it's more blood sugar, but I wasn't sure if it kind of, the risks go hand in hand.
So you are, if you've had a hypertensive disorder of pregnancy, you are more at risk of developing type 2 diabetes in your future.
Wow.
They are separate conditions.
Okay.
You may have both together, but uh, they're not related per se, other than having potentially shared risk factors.
Are
I
there,
think
yeah.
they have more postpartum impact. So if you've had gestational diabetes, you may be at higher risk for having type 2 diabetes in the future and or cardiovascular risks in the future. And then same thing with hypertensive disorders in pregnancy, you may have higher risk for developing diabetes in the future and or hypertension and other cardiovascular risks in the future.
What are the risks to the baby if are there risks to baby if the mother has hypertension in pregnancy or high blood pressure?
Do you want to take Karen, do you want to take the diabetes piece since you run the 6-month postpartum class for that?
Sure. So if we're talking about gestational diabetes, so diabetes in pregnancy, then the baby, well, because we're doing a fairly good job at identifying the moms who are having this. We usually keep our moms in a really good spot in terms of blood sugar. They're often referred to a diabetes clinic or a gestational diabetes clinic, I should say, to manage this. And so we are sort of aiming for and providing a normal glycemia type of environment for baby. And typically speaking, this lowers the risk. But of course, if we've had trouble with that, then it can increase the risk for baby for, I guess, and it's partly in the genetics that baby can have a higher risk for example, type 2 diabetes. Immediately, I think after delivery, there is a concern if we have had gestational diabetes and they're closely monitored. So we're worried that baby might be hypoglycemic. So, but there's a lot of careful monitoring at that time, probably an extra night's hospital stay in Ontario or just closer monitoring. So a lot of pokes for the baby's foot to check the blood sugar there.
Okay. And is it ever missed in people where they have gestational diabetes, but the test doesn't catch it, or is the test pretty good at catching and screening for it?
I think if you're seeing a healthcare provider during your pregnancy and you're going for that, I think now providers are suggesting anywhere between 24 to kind of 28 week to do your sugar test. It's usually caught. Some providers are saying, and Karen and Dr. Fleming, maybe you can verify to even pushing the envelope a little bit more to test at the 28 weeks can make sure we don't miss it. Because if something presents at 24, sorry, if something doesn't present at 24 weeks, but we had checked at that time, but ended up happening at 28 weeks, sometimes we miss it. But I think that's the window in general that we're testing.
We have we have good screening tests for, we do the initial screen, and then if someone screens positive, we can do a definitive test. So overall, we're doing a pretty good job of capturing those who are at risk for developing the gestational diabetes and treating them. The world of the hypertensive disorders of pregnancy, perhaps not as good a job, particularly after someone has delivered, because it's just not well known. Whereas it is pretty well known that if you had diabetes in pregnancy, then you are more likely to be at risk for developing diabetes in your future. So what the literature tells us is that both physicians and people themselves are more aware of that risk and are not as aware of they have high blood pressure in pregnancy, that
Also a risk.
for
Yeah.
their future health. So that is part of the knowledge gap that we're
Yeah.
trying to
What you're trying to change.
overcome and change. So it's so we're very happy to be able to share that information because we know that preventative care is, and there are things that can be done. So important to have the opportunity to lower your risk and impact your next pregnancy as well and future health.
Exactly. If people want to have a second or subsequent baby and they're already impacted with their first, it sounds like it doesn't necessarily mean that they cannot have another child. They just have to be more careful with monitoring and likely get back to being active. So this is where, I know fitness isn't always the number one goal postpartum, and it doesn't have to look like being in a gym, 5 days a week. You can get movement in other ways. And this is what people like me, this is what I help people is to get strength training, mobility, whatever it is that they want to do, get it in a way that actually fits their lifestyle postpartum. One question I have is, I know that in hypertension in particular, or heart disease in particular, is there's some ethnicities are more impacted by that. So for example, South Asians are at elevated risk of heart disease, right? So high blood pressure is also one of the things. Um, do you find that there is more routine screening required for certain ethnicities when they're pregnant or even postpartum follow-up? Is this something people need to be aware of, that if they have higher risks?
So we do know that Black women are more at risk of developing high blood pressure in pregnancy, for instance. So there are ethnic, some groups that are more at risk than others. The management and screening is similar, but
The same. Yeah.
the risk is greater.
So if somebody's listening and they're Black Canadian and they're like, you know what, I maybe need to be extra careful just to be screened, right? Even if they don't necessarily have a family history. The aspirin recommendation, I'm curious about because I'm hearing more about this now. Who would be the person who would recommend it? Would it be the family doctor or would it be the OBGYN or the midwife? Like who would play a role in recommending that the person take that preventively?
It could be all of the above.
Okay.
There are guidelines that for when to start it, and so if say you were planning for your pregnancy with your family physician, then they would talk with you about it and tell you when to start it. You may or may not see the provider who's going to care for you in pregnancy until after that first trimester.
True.
So,
Yeah. You might not see them till 12 weeks and then it's kind of like, yeah.
so it could be the midwife, it could be the family doctor before, it could be your nurse practitioner before, it could be your OBGYN when you come to that visit. So it could happen in all of those areas. And then part of what we do at the postpartum visit as well is that we will remind people that knowing that there's a lot that we cover at the 6-week postpartum visit. So it may not be top of mind, 2 years from
Yeah.
now. So
Yeah.
and it's really important for us who do deliveries to share that information back with both the person who is pregnant as well as with who's going to care for them going forwards, right? We don't want to miss providing that information.
Because there is it's all a bit of a blur, like the whole labor, the birth, the whole, week around that. And so I can imagine if information is given, then also to make sure that it's given to the people caring for that person so that it's not, they don't fall through the cracks, right? It's one of the things that I'm curious about is also mental health and how that might impact. Does it go up? Are these conditions more common in people who may be having mental health challenges? Or we did briefly talk about stress, but things like depression or perinatal anxiety, do those also play a role?
So we know that the people who've had, like all people postpartum, that mental health and physical health are both very, very important. And that if you've had a complicated pregnancy, or whether that's whatever that complication may be, but it may be that you had early onset preeclampsia and you had to deliver early and it wasn't what you anticipated or expected, is understandable. And we see that people are, it is a risk factor for anxiety, depressed mood, and depending on the nature of what happens, it could be more so. So mental health supports is important for all people postpartum. It is one of the reasons that we involved our dietitian, our health coaching, and also our social worker to participate in the workshop, because it is such a key area of need in the postpartum period. So
I really like that you have like a holistic view on this, because it's, I think so often in the perinatal space, it's like you go to this specialist to do this and you go to this specialist, and they're not always communicating and they're not always kind of coming together. So I really think that having all of you on the same team kind of communicating together and offering a workshop is really helpful. Can you tell me about your next workshop, or what your workshops are like? How do people sign up? Because I'm happy to share that information with my audience and with my patients as well.
So people can sign up for the workshops through our website.
Okay.
And there's a QR code, and they can sign up for the workshop. We're running them every 2 to 3 months. It is an opportunity to it's an interprofessional group. So we have Karen will be there as a dietitian. I facilitate as a family doctor who does obstetrics. We've got a nurse with health coaching expertise. We have our social worker doing to discuss mental health. So it really is more of a holistic approach, and talking about all the different areas where dimensions that around education and empowerment for your future health. And so I think that's really part of the good piece of this, and your resources are given out afterwards. So you're not
Amazing.
one and done, but you also, there are some resources that are available to you afterwards, depending, and we will send a letter to your family doctor or nurse practitioner afterwards, so that they know what we've talked about. They've known what sort of we recommend going forward, and what potential resources there are in the community. So Karen spoke to at 6 months, they've been running through Sunnybrook quite a wonderful post GDM workshop
Nice.
for people, and that is really what we modeled this on, in order to provide that opportunity for information and being able to empower you going forward.
Amazing. And these workshops, do they have to be referred to sign up, or anyone can go to the website and they can sign themselves up in pregnancy? And it sounds like it's for pregnancy or postpartum. Am I right?
For postpartum.
It's for postpartum. Okay. So it's for
Postpartum.
people who have been diagnosed with one of those conditions in pregnancy and now what to do, for themselves postpartum. What is, yeah.
Sorry, to sign up, it's hearthealthmatters.ca
Okay.
/workshop sign up. We also have an Instagram, which is Heart Health Matters Hub. And yes, it's a virtual workshop that's delivered. And the next two that are happening that we've planned for is June 26th in the afternoon, 2 to 4, and then September 25th, same thing in the afternoon, 2 to 4 over Zoom.
Amazing. It's so convenient. So people can attend this. They don't have to, come in person and they're still getting all that same amazing
So
information.
that was actually one of the things that we learned from the gestational diabetes group postpartum was that actually their partners was also able to come,
Yeah.
which helps with kind of that, when you're 6 months postpartum, or even we have people that join 4 months or 7, 8 months postpartum, you're still could be a little bit sleep deprived. You don't hear two people in the room listening to information can be a lot more helpful than just one. And then the access, I mean, initially it was because of COVID that we switched to virtual, but it just meant that often a little bit more moms could attend,
Yeah.
you know, so it was really helpful. And one thing to sort of speak to the mental health aspect too is the mom groups or parental groups that are available in the community are really important and helpful for that networking, for information sharing, and just for support. So things like early on, there's more private ones that are fee-based, but early on is one that I really try and get people to go to. And it's
I loved early
technically.
on. I went with my first. My second was born in the pandemic, so nothing was open, of course, but um yeah, super super helpful. The isolation is very draining because especially if you're a social person and you're used to being around people, even though your baby is a person, they're not necessarily talking to you and communicating in the same way you're expecting. And sometimes you're like, I just want to be around adults. And so I love that you talk about that in terms of mental health and these groups, they would get us moving to sometimes. I've done many talks at early ons on physical activity and, physical therapy, pain management, how to lift properly, all these simple things that you think are intuitive, but they're really not. And for an exhausted new parent, it's just so helpful to provide this information. So I'm grateful that this exists, and I hope that it, is something that takes off and that people, I just think a lot of people don't know about it. So this is, your first step is spreading the mission, spreading this information around. One thing that I meant to ask is what is HELP syndrome? Because that was another thing listed on your website. Is that something that falls within that 7% risk of hypertensive disorders? And if so, what is it?
So it is so you don't, interestingly with that one, it falls into the same family. So it's within the hypertensive disorders of pregnancy. However, it doesn't come with hypertension necessarily.
Mm.
So it is a cluster of changes in blood work. So it is rare and rarer, but it is a significant complication.
Okay.
So
Okay. Something for people to be aware of, right? Is that might also link in with this, but it doesn't necessarily mean high blood pressure. Um, and one thing this is anecdotal, but magnesium. I have known patients to take magnesium to help manage their um, blood pressure. And so I don't know if there's any validity to this, but would that then bring down their blood pressure and make them seem like it's all normal when they're actually not? Would that mask an elevated blood pressure as taking supplements?
to the best of my knowledge, I do not think that magnesium would mask someone's hypertension in this
Okay.
in this setting of pregnancy.
Okay, good. That's good to know. I've heard of this a couple times, and I was like, I don't know if magnesium alone is going to do anything major, but I also know that, um, yeah, I just was curious because
And
I had
I
no
think
idea.
part of the aspect is like how much of these supplements are we taking? Like, is it,
Mm.
factoring in often like the bioavailability? That's why those doses are often a little bit higher. That said, we can get many of these nutrients from food, and it is a factor of looking at are you one of those populations that have a higher risk because you don't eat a lot of foods with magnesium or calcium or iron? And that's when the supplement is really important. So of course, I'm biased as a dietitian. So if you have access to dietitians, they're good to talk to even once in your lifetime because it might help you understand some areas that you need to just be aware of.
in Ontario, how does somebody go about working with a dietitian? Is that something that again needs to be referred to, or is it direct access?
So if you're part of a family health team, where your family doctor works in a FIT or a family health team, you should normally have access to a dietitian. Same idea with the CHCs or the community health centers. There's often dietitians there. There are dietitians in the diabetes clinics, diabetes prevention programs, diabetes education centers. They may not specifically look at a postpartum hypertensive disorder in pregnancy type of look, but just know that that's somewhere that you can find somebody. And then ultimately it is private practice. Typically, people cannot access the dietitian in a family health team unless they're a patient of that
Of
family
that family health
practice.
team. That makes sense.
Correct. But again, many of us host sessions and information classes that are geared towards hypertension or cardiovascular risk that is open to the public. So, for example, at Sunnybrook, I have that opened up for anybody, even if you're not part of the family practice, but I don't provide the individual counseling or the kind of
Yeah.
one-on-one session.
Yeah.
And then dietitians are not OHIP covered, so but they may be covered through your health insurance plan if you're seeing somebody privately.
Yeah. Similar to physiotherapy, right? If
Exactly.
many people have insurance for it, but um, it's rare that it's OHIP covered in Ontario.
And that's part of the discussion around primary care teams, right? I know we're
Yeah.
in the spotlight in primary care, most recently in Ontario at least, so I can speak to that. But it is so helpful and important that we are looking at all areas of care because I think it's not enough for one person to take on all the pressures, which is the family doctor or the nurse
Yeah.
practitioner.
Yeah.
Things get missed not because of their fault, but because there's so many things happening
Yeah.
with one person, but also so many patients. So,
Yeah. And it's not necessarily their area of expertise to touch on every single aspect of the person's health. And I think that's where the team collaborative approach is really beneficial. Because so often, even with I can speak to exercise. People are told you should exercise, but knowing that they should and actually being able to do it, knowing exactly how to take that step to getting more movement, especially if they have pain or any symptoms, it's very tricky. And that's almost always going to be a barrier. Or if they're stressed, overwhelmed, it's like, how do I actually get movement in? People are often like, I'll wait till I lose weight. I'll wait till I'm less busy. I'll wait till I'm less stressed. But we need to still move through that, and it can actually help with all those things because movement helps with mental health, physical health, pain, all the things. So I can definitely see that, similar thing happening with the nutrition, um, and a variety of different aspects of healthcare. So thank you, Dr. Fleming, and thank you, Karen, for your time and your expertise. Is there anything else that we've missed today in our conversation that you would like to share? If so, please do.
I think if I could ask you to take one thing away from the podcast is that remember to tell your healthcare provider what happened in pregnancy so that you can work together for future health.
I love that. I don't remember going back and telling my primary care provider anything. I mean, there wasn't much to tell, but I don't really remember that being a conversation. So I think being intentional and planning to tell your doctor, even if they don't ask about it, would be a really good take-home message so that they're up to date on what's been happening, on your health, on the side of your health. I will share all the links. So Heart Health Matters Hub is Instagram. Hearthealthmatters.ca is the website where you can sign up for the workshop. I'll share the link to sign up for the workshop as well. And if you have any questions at all, I will share, where you can connect with them so that you can find out more.
Okay.
thank you.
Thank you.